Hi, Dave.
Hey, how's everybody?
Good. Did you?
No,
Oh my gosh, fine.
I'm sorry.
I thought you said no, but did you get the date kind of finalized for us, or what's the dealio?
Nope, I just need to talk to Matt. And I kind of just hadn't talked to Matt since I was away last week. So in that window of time you have, it shouldn't be a problem. So what we're gonna end up doing is in that window is we'll schedule basically a clinical reasoning portion of it with Eric and I, and then probably do a skills, and we'll schedule a skills assessment with Matt in that period of time. So I'll try and get you a date, and I will email Matt while Eric is talking at some point today. How's that sound? I will include you on the email.
Love that. Thank you.
It looks like you guys had fun last week. It's kind of a cool topic.
Wasn't so bad. Assuming I can find where I saved this thing and where I put it.
Yeah, you could share the screen. Cool.
Yeah, I'm just looking for what file I have this under. Guys, got any questions in the meantime while I'm searching here? We spent a good amount of time answering questions last week, so if there's anything that you guys want to talk about while I'm looking, we can do that first.
I'm just really struggling with two different low back sacral dysfunction and not and innominate. Like keep reviewing my notes and making sure that I'm doing the right treatment for what I'm seeing, and I believe I am, but it feels like they return with the same problem each visit.
So they're having sacral pain, SI joint pain. Is that what you're diagnosing?
Mm, I would say one of them is SI and the other one's more low back.
Okay. So where's the confusion coming in? Is it coming in with how to treat them or how to get it to carry over?
How to get it to carry over, and then I think I still struggle with um the assessment portion of this, like the sacrum and the innominate um stuff working together basically.
Okay, so there's a bit of a process to the lumbar exam when we're looking at this sort of stuff. So go on, sorry, dog. We've got kind of a sequence of things that we want to go through when we're doing that sort of stuff. All right, here, take it, go, run, chew. Um, Basically we want to start with cardinal plane movements, right? So we'd ask them to go through flexion extension, side bending motions. What we're looking for is a distinct loss of range of motion in those sort of scenarios. Okay, something that'll show us this type of movement is dysfunctional, right? And we want it to kind of lead us in a particular direction. If we find that there's, nothing that's really jumping out at us right off the bat, so we go through those four cardinal plane movements and we say, okay, there's not really much that's suggestive of a significant problem in those cardinal plane movements. We have to add in combined movements. So then we would go into our quadrants. We'd go into extension, left side bending, extension, right side bending, and we may find, kind of a mild, very mild, 10, 15% restriction of movement in the cardinal planes. And that might guide us in a particular direction, right? So if we lean left and we're like, yeah, that's not quite as smooth, the curvature of the lumbar segments doesn't look as smooth going to the right as it does going to the left, we may look at right extension first. We may look at right flexion first. That should lead us into a situation where we're saying, okay, this may or may not be a facet issue, may or may not be a disc issue. Kind of gives us an idea of where we might be going with it. From there, I usually do some sort of um, kind of like a lateral shear type of test, like a translational test for a lateral subluxation of one of the lumbar segments. Basically, it's just the hand on the shoulder, the hand on the opposite side of the pelvis, and we're just shearing from one side to the other. Looking again for a significant reproduction of pain, which may suggest like a contained herniation, or a significant limitation of movement, which may suggest a lateral shift. Okay, so should have a pretty good idea of what those things might be, whether it's going to be more of an articular problem, maybe a disc issue, an instability, lateral shift, etc., from just those few things. After that, while they're still in standing, I'm going to do some sort of SI joint screening test, whether that's our Portland test or whether it's one of our kinetic tests. We have the ipsilateral, contralateral, etc., as far as those go. Or we could do a forward or backward bending test. These are not tests that are going to give you a lot of diagnostic information. They're just going to be something where it tells you, hey, there's something going on this side of the pelvis, right side of the pelvis, left side of the pelvis, whichever one ends up being positive. And it means we have to do more deeper biomechanical exam. Now, the biomechanical exam for the pelvis is really pretty simple. We have, if it's painful, we will typically do primary stress tests, which are going to be our anterior compression, anterior gapping, or posterior compression, posterior gapping. They're essentially the same thing for reproduction of pain. Okay, once we get through those, if they're not having significant pelvis pain, then we don't necessarily have to do those. Then we'll also do basically our pivums and pavums, anterior, posterior, rotational motions of the innominate. So lying in supine, and we're just going to do kind of these sort of ideas to see if one side can or can't rotate posterior or rotate anterior relative to the sacrum. Generally, that's what where we're going to find our restriction is with those supine, quote unquote, pivums and pavums. If we are dealing with something like a sacral torsion, where the dysfunction is actually more of a positional fault on the oblique axes of the sacrum, we may have to flip them onto their belly and do pivums and pavums in that position, which would involve us taking either the ILA, so that inferior lateral angle, and trying to push it anteriorly, or on the sacral base, so the superior lateral portion of the sacrum, and pushing that anteriorly. Now that will give us more of this, kind of oblique tilting of the sacrum relative to the innominate, the connection with the innominate. Generally, when I'm looking at SI joint problems, outside of maybe 3 risk groups, you're looking at the SI joint issue being a secondary problem, meaning it's being driven by something somewhere else within the kinetic chain. Now, that could be something in the TL junction, in the mid-thorax. It could be something in the lumbar spine. It could be something in the hip. It could be something in the ankle or the subtalar joint. There's really no ideal way to say that this is definitively where these things are going to come from right off the bat. But I have noticed that in most cases, a innominate rotation, which is generally easier to correct, will come from either something coming out of something stemming out of the thorax. So, via these long thoracic paraspinal musculature, or maybe the QL, if it's coming out of the TL junction, will create an innominate rotation by kind of pulling on that PSIS and creating that anterior tilt unilaterally of one side of the pelvis. Okay, so innominate rotation I see a lot from thoracic lesions. I also see it a lot from hip problems or any other issues that go down into the lower extremity. Sacral torsions I tend to notice a lot more with lumbar pathology, primary lumbar pathology. So an old disc lesion, lumbar instability, a facet irritation or inflammation, something of that sort of nature, lateral shifts, those sort of things tend to, and again, I'm using the word tend to here because there are exceptions to every rule with this sort of stuff, and I wouldn't even call it a rule per se. I'd call it more of a commonality, more of a profile. Generally, those things are going to create some sort of lumbar motor imbalance, affecting either the short hip external rotators or potentially the psoas itself. And those two things are more likely to create these oblique torsions through the sacrum. Okay, so they're more difficult, I think, to find because when we're doing our pivums and pavums, they're going to present very similarly to an innominate rotation. And again, when we're looking at the difference between an innominate rotation and a sacral torsion, we're only talking about it in separate terms because it implies that there's a difference on which component is being acted on by these abnormal dysfunctional muscle tones or forces or whatever it may be. It's either acting on the innominate, creating a rotary component there, or it's acting on the sacrum itself, creating a torsional force. Now, generally what I will do is I will look at what the cause is, what my suspected cause is. So if I say this patient comes in and they're saying, here's my pain, it's a Fortin's point pain, and I'm thinking, okay, I do my screening test and I look at, say, the Portland test and it's positive, I'm going to say, yeah, this looks like it's an SI joint dysfunction. Where is it coming from? Okay, where is this potentially coming from? That's when I'm going to get into my quote unquote screening tests that we've been kind of harping on you guys for what, a year now, year and change now. Just these quick screen tests that we can look at to see if other particular areas that we know are common problems that affect the SI joint, whether or not those areas are dysfunctional. So I'd have them sitting, I'd look at seated rotation for the mid-thorax and the TL junction. I'd go through active range of motion testing and probably quadrant testing of the lumbar spine. I'd go through quadrant testing, probably active passive resisted testing of the hip. And then I'd probably look at, again, active passive resisted testing for the ankle itself. And I'd probably stop at those four things right off the bat before going into looking at, knee hyperextension problems or subtalar joint issues or midfoot problems. Because in most cases, one of those bigger issues, thoracic spine, lumbar spine, hip, or ankle, those are really going to be probably, oh man, I hate giving numbers or percentages, but maybe 90, 92% of the problems that you're dealing with that are causing SI joint issues. And then if I find a problem with one of my screening tests, then I know I have to go in, I have to examine that area more in depth. If I end up with more than one particular area, say I have a limitation of seated rotation and a limitation of my hip quadrants, I have to decide via my own clinical judgment which one of these things is most likely to be causing this patient's problem. If they're a runner, I'm probably going to lend a little more credence to the hip. If they're a rotational athlete like a golfer, I'm probably going to look more at the thorax, right? So we have to make those determinations based off of what we see. But that's kind of the process that I would go through. And then based off of where the as far as carryover goes, based off of where the driving mechanism is coming from, right? So if I've determined the thoracic spine is my driving mechanism, that's what's setting off these SI joint issues. My carryover focus, my home exercise program is focused on restoring and maintaining adequate function through the thorax. So I'll generally have some sort of self-mobilization or self-mobility task that I'll give them. And then I'll give them some sort of movement re-education thing, which a lot of times I do, especially initially, is with banded motions or Pavlov presses with the trunk rotated in a particular situation. Basically, we're trying to get these motor patterns to be more efficient into the range of motion that we just had to restore, right? So if they couldn't turn right, I'm going to give them some sort of self-mobility thing to maintain the articular mobility going to the right. And then I'm going to have them do something that focuses on re-educating that motor pattern while moving to the right side. Okay, that's the stuff that I think is going to give you the most benefit as far as carryover. We've done in the past plenty of things where we give them like little push pulls or something like that with the legs. I showed you guys that stuff during module 5, just to try and keep the SI joint mobile if it was limited, if there was some sort of articular limitation there. But a lot of times if we can correct the driving factor, the SI joint stuff, the pelvis stuff will self-correct itself. We just have to keep it mobile long enough to do that. I know you use a pretty similar process with that stuff, Dave. You have anything you want to add there?
That's a pretty elaborate description, actually a really good description of kind of the sequencing you go through. And again, it's usually the only thing you find is in real time. What you tend to do is exactly what Eric said, you're kind of parsing it down to be the individual. If it's a runner, then I'm probably going to sequence it, toward what I'm seeing with that runner, thinking lower extremity driven up first. Right, rotational athlete, then yeah, it's going to be hip, spine that I'd be focusing on what may be driving it. I think when I look at SI joints, kind of an innate thing. It's like I tend to think of like spine drivers for like sacral dysfunctions and bigger gross movement pattern dysfunctions like innominate as a general rule of thumb. And when I find it, when I go in and look, it's I find what I find. But I don't go in with a blank slate per se. I go in with, okay, here's kind of commonly what I see. Do I see what I commonly see? Or do I find information that's different when I'm looking at this? And again, this person keeps coming back after correcting and uncorrecting. There's either a vector that I've missed, or there's forces in their everyday life, walking, gait, sitting. There's an external driver, a muscle vector coming from the longissimus iliocostalis that's pulling this thing into a position, which is probably there because of either a driver within the system or externally, posture, standing, sleeping.
Yeah. Yeah, and
So-
that's essentially what we were just talking about, right? It's just like, if you're missing, if it's continually repeating itself. Now here's then yeah, like Dave said, there might be a vector, there might be some other thing that's kind of a co-driver or something else that's contributing to these sort of factors. That happens all the time, right? I've had patients come in and I'm looking at it, I'm like, yep, this looks like a pretty cut and dry thoracic issue affecting the pelvis. We'll fix that sort of thing. And they come back in and it's just like, yeah, 70, 80% better. I'm feeling more comfortable. Thoracic spine looks like it's moving fine, but the pelvis looks like it's off again. It's like, well, maybe there is some other factor that's playing a role here down in the foot or the ankle or the hip or something that's also still contributing to abnormal forces crossing that pelvic region. The hard part with the thorax situation is it's pretty notoriously difficult to maintain mobility of the thorax in general after treating it also. And I think the two biggest reasons for that are posture, right? So sustained positions that patients have. Hell, you can look at me right now sitting in front of my computer, leaning forward, looking at the screen. Patients that do that stuff for 8 to 10 hours a day, and then they're like, well, I'm going to go hit the driving range on my way home. And they expect their body to be able to handle that dichotomy of situations just like that without, any major issue. And maybe it can when they're 24. But when they're 38, it may not play that game quite as well for them without doing something to help loosen themselves up. So sustained positions or postures, I think, are a problem for carryover in the thorax, but then also the respiratory mechanism, right? So the way that the ribs are able to move in order to produce expansion of the chest wall, habitually, it's a very big problem. So if you think about, let's go back to our golfer, and we have a golfer that's on the tee box or at the driving range on the tee box, and he has this faulty swing, right? He's doing something wrong with his swing, but he stands there and he's like, I'm going to get this right, and he takes 1,000 repetitions with this faulty swing. He's going to have a real tough time breaking that habit when he's practicing, right? He's going to he gets a coach, somebody comes in and says, this is what you got to do differently. And he's just going to have a hard time breaking the habit that he's made because he's taken so many repetitions doing it improperly. Well, we take upwards of 1,000 breaths every hour. And if our rib cage is moving dysfunctionally, meaning we have a rib that's kind of, say an upper rib here that's swinging out in kind of this bucket handle motion when it's supposed to be doing more of this sagittal plane pump handle motion, in 1 hour, we're doing almost as many repetitions as that guy on the driving range. So you can imagine if these things have been there for any length of time, 2 weeks, 6 months, some of these thoracic lesions can be there for years before they start to develop significant biomechanical adaptations elsewhere. The rib cage is very good at adapting to things. That's part of its mechanism. But eventually it's going to run out of ways to do that. So you can see how sometimes breaking these habits, especially with things in the rib cage, can be difficult. So I wouldn't get too worked up over a patient that comes in on day one and you do something to treat it and they're moving better when they walk out, but then they come in 2 days later or a week later or whatever it may be, and it's not moving great again, especially when we're dealing with the pelvis, because we have to correct other things in order to really truly treat the pelvis. Or especially if it's the thorax that you have to deal with, because these carryover mechanisms are real tough to get. So that's going to be something that we should probably make a habit of telling our patients when we're going through, the things that we want them to do at home. When we're talking about the re-education process, and we need to let them know this is a process. This isn't something where we're going to come in, we're going to manipulate it, and you're going to go back to normal. In most cases, these things have been lurking around a little while, and something finally broke down, and it's going to take us some time to re-educate that stuff, and correct some of those dysfunctions. That should be okay. I think we, as manual therapists, we like the situation where a patient comes in and we do something, we treat them, and boom, they're feeling better right away, and we get them kind of going right back to where they're going to be. And they're in and out of our office in 3 or 4 visits. I mean, it happens. It works out that way sometimes, depending on what the problem is. But I think we get kind of keyed in on those situations, and we hope for those situations every time somebody comes in. But unfortunately, that's just not going to be the case. So yeah, again, like Dave was saying, kind of a long-winded answer as far as how to look at the SI joint. But I think the biggest thing that you can do for yourself when you're looking at the SI joint there, Ariel, is understand that there's very likely to be something else that's a driving factor here, whether it's, like we said, thoracic, hip, lumbar, etc. And those are the etiology components that you really have to focus on in order to get these things to carry over. Last little thing I'll say about it is the 3 things I mentioned, 3 things that can create primary SI joint pathology. Number 1 is children under the age of 12, where the joint's not fully formed yet. We can get primary subluxations of the SI joint in those sort of scenarios. Pregnancy, so pregnant females where there's enough mobility within the joint for it to sublux on its own. And number 3 is some sort of active inflammatory condition or other condition that destabilizes the SI joint, essentially creates an instability in the SI joint. And those should be readily apparent on our secondary sacroiliac stress tests. These are the ones where we're having laying prone and we're trying to shear the sacrum vertically up or down relative to the innominate. Okay, so those are the kind of the 3 scenarios we may find where we can have a true primary SI joint dysfunction without really having to chase down a driving mechanism elsewhere in the body. All right. I'm off my soapbox on the SI joint. What else we got? Anything? Or better yet, Ariel, does that at least point you in the right direction here?
Yeah, a little bit. I feel like I've done a lot of those things, but I'm going to go back and reassess.
Yeah. And again, it could just be a situation where the problem with the carryover is the carryover with the etiology and not the pelvis or the lumbar area, right? Where's the forces coming from that are causing this issue? That may be more where you need to focus your carryover tasks.
Yeah, what's the primary task or primary limiting task?
Oh, one is a theater performer, dancer recovering from a labral hip labral repair, and she has repeated pain with side bending that is being caused by the hip flexor, or that's what I think it is. And so she continued, like when I correct the nominate SI, low back, I've done the thorax, I can improve it in session, and then it returns between sessions. Sometimes not as bad as others. It depends on what she's done in between. And I've still been able to progress all treatment, but that pain, the dysfunction with the hip flexor has remained.
Where's the location of the pain?
So when she side bends to the right, it's in the left side where left side was surgical. And it will either be towards the back or towards the front, but basically over the top of the iliac crest.
So posterior pain is posteriorly over the iliac crest on the left-hand side when she bends right.
Yes.
Is that correct? Right. How
Yes.
long does it go away after you treat her? 2
So
hours, 2 days, a week?
I've asked her and she says I notice it 'cause she will teach like aquatic fitness from land. So when she's doing those things, so if I see her midweek, it's whenever next time she teaches. So sometimes it's 5 days, sometimes it's 2 days. She'll notice it when she's teaching the class. And then she notices it in the morning. And so it can be 1 day, sometimes it's 3 days. But it keeps coming back. They went back and they were like, maybe it's a gynecological issue, something going on with your. They thought maybe she has cysts, which she might have cysts, but the pain just really is like all points to hip flexor, not.
Yeah,
It's not as much there.
that would be unlikely that she'd be able
Yeah.
to affect the pain just by side bending because of.
Yeah, I mean, that's
this.
what I said.
I mean, it's not unheard of, I suppose, to have that, but it would be more vague. It wouldn't be so specific. Have you just done palpation over that iliac crest? Is it tender to touch?
Not on the bone or like glute tenderness, hip flexor tenderness through the
No.
anterior portion.
Did you check the quadratus lumborum?
I've worked on it.
Okay. Is it bothersome? Does it reproduce pain?
No.
No. Okay.
Needled it.
Well, it's work comp. And I was
Hmm.
needling and they approved 8 visits and I've had the doctor repeatedly write an order for it and work comp won't approve it anymore. And yes, I want to needle it and they won't let me.
So you haven't needled it.
I didn't needle QL, I've needled glute, hip flexor, quad. I did in the past, but I'm not approved to do it anymore, so I can't do it.
Okay. So here's 2 things that I would look at. If palpation of the QL, especially along its attachment to the innominate, is not reproducing pain, the pain that they are complaining of, I would look at the possibility. There's a thing called the iliac crest point, and it is a reference of pain from the T12 L1 segment that appears right across the top of the iliac crest, usually pretty laterally, so more toward the flank. So
Okay.
I might do a deep dive into T12 on that left side.
Okay.
The other option is the other thing that just when you were talking made me think of it, is the side bending in particular causing the issue. I would look for the potential for an actual lateral shift within the lumbar segments. L4 is going to be your most likely culprit there. And basically what it would be is it would be a left shift of probably the L4 segment. Now you can test for the L4 segment to be problematic by doing velocity dependent force output testing. So speed dependent ankle dorsiflexion testing should give you a very quick idea that, hey, there's a facilitation here that suggests problems at L4. And then you can go in and you can actually do just a straight lateral translation. So going left to right on L4 over L5. Now that's something that could very easily cause that same sort of flank pain. A lot of times they'll have a reference into the leg with it, but it would probably not get much past the knee. But that'd be another thing that could perpetuate the hip flexor issues, because L4 has a very significant feedback loop with the psoas major, so that could be causing some of the problems with hip flexor tone. It could also cause, because of hip flexor tone issues, especially psoas major tone issues, it could continually cause an anterior shear against the anterior labrum, which could have been part of the reason that started to break down in the first place, and required surgery. So that'd be another spot that I'd take a look at. You could just as easily say, we're going to look at look for distributed weaknesses here. And you can go through the entire lower quadrant if you'd want to, as far as testing for speed-dependent weaknesses that would suggest lumbar pathology that might be affecting motor tone. Okay, and if you find one that's consistent with a particular segmental distribution, remember if you get it in just one muscle group, it's not necessarily going to convince us that it's segmental. Now, with speed dependent weaknesses, we tend to look at that more as more likely to be a segmental issue to begin with, because there's very few other things that are going to give us speed dependence issues other than lumbar, like we said, spinal segmental issues. Now, it could be a subluxed facet, could be an instability, could be a hypermobility, could be an old disc lesion, could be a lateral shift. You have to figure that out with your biomechanical examination of the lumbar region. I would look at, when I'm dealing with a pure side bending motion issue, I look at lateral shifts more consistently just because that's what it's most likely to affect. But those are a couple options, couple things you can kind of check into, and hopefully that at least gives you something to work on, and gives you some more data points when you start looking at how to put this stuff together again.
Okay, thank you. Appreciate it.
Yep.
There's one question. When she laterally bends, to the right, if you looked at, what happens at the ankle, hip, lumbar spine, and thorax.
I haven't looked at them when she's doing that movement. I've looked at her movements there, but I haven't looked at it when she's physically.
I want you to look at her pain producing movements. And what you want to see now is you have all this knowledge, okay, what should the ankle be doing when I laterally bend? Okay, if I'm laterally bending to the right, what's my right hip doing? What's my left hip doing? What's my nominate going to do? What's my nominate rotation that happens with that? Is her thoracic spine, is she getting side bending motion through that system? So, base camp with this in your evaluation is, what is the pain provoking motion? Now take all the joint biomechanics we've gone into, and am I getting everything from the system that I need? And if I'm not, it goes back to kind of what Eric and I are talking about. This is like the 360 view of it before I even go in there and check rib translations and muscle tone. What stands out? If her thoracic spine isn't side bending as she does that, she's not dissipating forces. Is it acting like a long lever and driving down into L4, L5 and causing the disruption there? Again, what's going to go on at the foot as she side bends that way? Is she going out the lateral arch or the medial arch? The hip collapsing inward. The hip should translate the opposite direction. So, take that 360 view and then bring it back down in. But take all what we know now about the biomechanics from the ankle. In this case, I go up through the thorax. And when I look at my pain provoking motions, is there somewhere that there's something that's off? And then work from there, especially if you're kind of in cases when you get kind of stumped where you have all this knowledge, you're not quite sure how to apply it. Take it back to its rudimentally what causes pain and what should each of these systems within there do. To unwind it. So that may help you frame it where that way you can kind of see, look, she has a long lever because she's slightly flexed through the thoracic spine, and this lever drives down into the lumbar spine. And if I have her side bend and improve side bending through the thoracic spine, she doesn't get this spike of pain in the left-hand side. Or maybe her hips aren't translating because she doesn't want to move through that hip because her proprioception and kinetic sense is off in that hip. So that's left over even in the absence of pain. So she doesn't translate the hips in the opposite direction of the side bend. And now all of a sudden, that's buggering up her lumbar spine. That's a force from below. So in this all too, it's the idea of use your biomechanics to not overlook the obvious.
Buggering up, that's a technical term, by the way.
Yes. Yep.
Coined first by Jim Meadows, I believe.
Mm-hmm. Yeah, it's been passed down.
We got to give credit where it's due.
Yeah.
No, can't take credit for that one. All right. Got about 25 minutes left, so probably jump back into our energy transfer discussion. Let me share this screen here. Okay. You seeing it? Hopefully. Okay. So again, we made it through, I think, four or five of these slides last week. And basically the gist of what we were talking about, if you weren't on the call or you didn't get a chance to go back and look at it, is we're looking at efficiency of motion with these things, right? So things like locomotion, are imperative for a particular organism's or a particular species survival. Being able to get from point A to point B, being able to get to food, being able to get to water. These are evolutionary imperatives that our bodies have not yet adapted to, because we haven't quite hit the stage yet where we've evolutionarily changed our body's imperatives, where it doesn't know that, hey, we can just go down the street to the grocery store and get ourselves food, or go down the street to the fast food restaurant and get ourselves something to eat. Our body still functions as though it still has to search or hunt for food. And I think the way that the human locomotion evolution has occurred is really one of the more interesting biomechanical and anatomical things that we can talk about as physical therapists, because efficiency of motion, particularly for humans, is one of the highest adapted evolutionary things that has ever occurred on the planet, and if you ask me, because our bodies are designed to use the least amount of effort for ambulation, compared to any other organism on the planet, right? And so we do this via a couple of things here. I think we talked about them last time, right? These 4 mechanisms, right? So a weight-bearing lumbar lordosis, hip joint that can extend beyond neutral, so beyond the plane of the trunk, the Q angle of the femoral neck. So what that does is it narrows our base of support and limits rotational displacement, by allowing our feet to essentially step one in front of the other, rather than waddling like a Barbie doll. If you're walking a Barbie doll with stiff legs, or a primate that kind of waddles side to side, right? It limits some of these rotational displacements when we look at that thing. And then the knee joint, essentially this could be considered like an asterisk version of one of these things. The first 3 are really the most important. But what this does is it creates a nice rigid pendulum for us to propel ourselves with, and it gives us a lot of other structures that we can use to help build and store kinetic energy, for use during something like ambulation, whether it's striding or whether it's running, right? So we talked a bit about some of Krakowski's papers here, the optimum spine, spinal engine, talking about legs and whether or not they're actually necessary. They're essentially a bonus process here. So like I said, they give us a lot of other real estate to use in order to help produce these passive kinetic energy things. But his postulation is that the driving mechanism for ambulation is going to be the psoas major and the multifidi of the spine. And basically what these things do is they create this torsional effect. They stretch the joint capsules of the hip. They stretch things like the TFL down through the IT band into the peroneals, which then cut underneath the foot, right? And these are all sequential tissues that are all interconnected via fascial interactions. So when we get into a position where we've completely stretched these tissues, so in human ambulation, it's during terminal stance, right? So right before we're about to have our heel lift on our trailing leg, everything should be pretty close to close packing. So we get all of these tissues that, again, they twist, they contort, they stretch, they elongate, and they get into these positions just like a bunch of rubber bands that have built up all this tension. And then when our heel lifts, as our forward momentum carries us over, to get that heel to lift via tension in the Achilles, and the gastroc mechanism, all of these structures, all of these elastic structures, or pliable structures, because it's not just joint capsules, ligaments, muscle tissue, connective tissue. We also get bending and pliability of some of the bones of the lower extremity. Things like the fibula, they're known to distort with some of these vertical pressures. The pelvis itself, the innominate bones are very pliable. They're known to bend and distort. The neural arches of the lumbar segments, as we get impaction of the facet joints, we get distortion and torsion of the bony material there as well. But all these things, when that heel lifts, they all recoil. Boom, just like that. And it's like a little explosion of energy just gets released. And it gets carried up through all of what we call these series elastic elements, or what Fred used to call as series elastic elements, in order to help propel this spinal engine, right? So that energy gets best distributed back into the psoas, back into the multifidi, via all of these interconnections with the fascia and bone in order to help prevent us from having to expend muscular energy, right? So we started talking about at the end of the session last week, the idea that if we are somehow unable to produce this passive kinetic energy, right, this stored potential energy via all of these structures within the lower extremity, we have to find a way, so for instance, I think the example we used last week, if we have a stiff ankle and we can't get the foot to flatten out properly because we're getting premature heel lift, so we lose all of that tension in the plantar fascia, joint capsules of all those joints of the foot. There's 37 joints in the foot. So all of those joint capsules and ligaments, they don't stretch as much as they should. And so all of a sudden we lose some of that stored potential energy. Well, in order for us to maintain the same cadence, right, and not have some sort of asymmetry side to side, again, that's going to force us to deviate and then recorrect. So again, that's just another wasted energy. We have to add energy back into the system somehow. And the most likely situation for that to happen is we're going to start pushing through our calf, right? We're going to start pushing via plantar flexion into the ground to propel that leg forward with more force. That can lead to structural breakdown at a certain point of the tissues that are associated with that. So trigger points within the gastroc-soleus mechanism itself, tendinopathies of the Achilles, tenoperiosteal irritation of the Achilles insertion onto the heel. It's another way we can develop things like plantar fasciosis over time via that fascial connection reaching under the foot. All kinds of different things that become problematic as we have to add that energy back in. The other potential option there is all of a sudden now we're pulling that leg forward more via increased use of the hip flexor mechanisms. So patients that get snapping hip, patients that get, tendinopathies there, that they're kind of into the groin, things of that nature, that eventually can start to develop into things like labral pathologies, capsular lesions, et cetera, that present with capsular patterns, can be caused by this lack of potential energy being stored. And we're overusing that hip flexor to compensate for the ability to propel that limb forward. And that has a whole bunch of other sequelas that kind of come with it, right? Because once we start increasing tone of the hip flexor, particularly the psoas major, we know via the anatomical insertions and origins here of the hip flexor of the psoas major itself, that it attaches to the anterior portion of the transverse processes of the lumbar segments, all the way from L5 up to T12, right, at the very least. And so what that's going to do, if we get increased tone of one side compared to the other, now we're going to get this situation where we get an increased extension on one side bending, right, as that pulls down, and then rotation of that segment. Now we have a rotary position of one of the lumbar segments or multiple lumbar segments, and it's going to be very difficult for the body to get out of that position when the opposite should be occurring, right? So if we're striding on the right side here, or my right side here, and we're in this position, but the hip flexor is holding us in this position, when we get to the other side, and essentially when the left side goes into a terminal stance position, it's going to be very difficult for us to pull that segment or multiple segments out of that kind of latexion position, right? Extension, side bending, and contralateral rotation. It's going to be very difficult to pull us out of that position. And so eventually we can start to get breakdown of other tissues on the opposite side now, right? How does that decompensate things? And where do we have to do that? Do we have to increase the amount of hip extension that we develop on that side? Do we have to increase the amount of genu recurvatum that we have to produce on that opposite side? Do we start increasing the amount of lumbar lordosis through the segment? So we're kind of stuck here. The only thing maybe we can do is we can continue to hyperextend that opposite side, right? And that can create linear shearing instabilities and whatnot through the lumbar segment. So you can start to see how these things can really cause a lot of these serial lesions that can potentially cause issues. Because as soon as we start developing this hyperextension or this anterior shear instability through one of the lumbar segments, what do we know instabilities and hypermobilities do to segmental distributions within their range? They tend to cause facilitations, right? Segmental facilitations. So if this is occurring at L5, this increased anterior shear is occurring at L5, all of a sudden we might start getting irritations of multiple muscle issues or tenomuscular issues on the opposite side, right? We could get peroneal problems. We could get hamstring issues. We could get hip abductor issues, all of these things, because now we have a facilitatory influence on the opposite side that's increasing all the tone of L5, all the motor tone issues around L5. So we're getting, the hip abductors are a potential issue. We're dealing with potentially the peroneals, the hamstrings. How do these things play with, whatever it is this patient wants to do with their life? Are they a runner? Are they a soccer player? Are they a rock climber? Are they a skier? Any of these things that are more dynamic movements, more dynamic activities where it's just like, okay, they really have to have this speed dependence weakness. This can't be there during some of these scenarios. And they could potentially have a rupture of their ACL because of increased hamstring tone, right? That sudden imbalance of resting and more importantly, speed dependent motor tone between the quadricep and the hamstring. Can't get adequate co-contraction in those situations because of reflexive inhibition, right? Or what we'd consider reciprocal inhibition around that knee. Increased tone in the hamstrings diminishes the effectiveness of the quadricep via reciprocal inhibition. Abnormal shearing forces may occur across the knee, and especially with dynamic activities. You start to see how it's possible for patients, and we've all seen these sort of things with professional athletes. You see the basketball player that's just running down the court, and all of a sudden they just drop like they got hit by a sniper, and their knee blew out doing nothing more than just jogging down the court. Well, these sort of scenarios where we have these facilitatory influences affecting the co-contraction around the knee in particular creates these abnormal problems, these abnormal shears, and boom, there goes the ACL. And meanwhile, they're sitting there going, well, we don't know how it happened, right? And it's just a freak accident, right? Well, maybe not. It could be some of these potential energy issues that this athlete, in a lot of cases, sometimes elite athletes, especially when we're seeing it in professionals, if they're not able to generate if they're not able to store this energy and transmit this energy from one portion of the lower extremity toward the pelvis, toward the trunk, you can see how some of these things may really become problematic for patients. So I do think this is fun stuff. Obviously not for the person that blows out their ACL, but in theory, this stuff is interesting to think about because it gives us a lot of other avenues we can go down. I mean, we're talking with Ariel about a patient that she has, and how this person is able to deal with these forces and where some of these come from. We're looking at that. The conversation we had with that is we're looking at it from a biomechanical standpoint. Is problem here affects muscle tone down to here, exerts force there, and there's our issue, right? It's a much more linear connection. But if we have an ankle issue that creates increased hip flexor, ankle issue on the right creates increased hip flexor tone on the left, affects lumbar position hip flexor tone on that same right side, creates that extension hypermobility on the left side, affects the segmental tone of, say, that L5, and we start to develop all these things, including hamstring issues, and that's what causes the ACL to burn out on them. How well is that patient really going to rehab when they're going back to activity, right? They get to the point, they're 4 or 5 months in and their doctor's clearing them like, okay, you can start doing a little light jogging or a little bit of light ballistic activity to start moving towards this. How well is that body going to handle that sort of thing? Especially now that they've had this surgical intervention. Now we're dealing with reflexive inhibition around the knee. There's been inflammation. There's been trauma, including the surgery, all that sort of stuff. It's just like, how well is this person going to be able to manage that sort of thing? So I do think there's some benefit to this sort of stuff when we have to be able to figure out how well can this person handle going back to activity. All right. Just looking at this slide here. Been talking about this quite a bit here for the first little bit, but energy is stored in a lot of these structures. So we look at collagenous structures, joint capsules, ligament, fascia, but the bone, I think, is one of the ones that we don't think about quite enough. We have to think about the idea that energy is not something that we can create or destroy, right? It's just the form that it takes can sometimes be changed, and we can dissipate that sort of thing. Ground reaction forces and gravity essentially should be equal forces against our body, right? We have gravity pushing down on us. We have the ground resisting that force. And so these two forces should balance themselves out. Otherwise, we either be getting stretched out or floating off the ground, or we'd be getting squished, right? So if an imbalance occurs there between those two things, we tend to lose the ability to produce this energy appropriately. Okay. But these sort of things, this statement here, wanting to minimize the amount of ground reaction forces and friction, basically means we're trying to avoid structural breakdown because of dissipation of excess forces, right? So the most common place that we get this sort of thing is via the first metatarsal head. First metatarsal head should have the sesamoid bones that come down underneath it, and they set down onto the ground just like this. And then the met head itself will spin over the top of those things. There used to be a real cool G.I. Joe toy back in the day that had this truck that would drive, and it had this bridge, right? And it would take this bridge and it would throw a bridge over water and then drive over the bridge and then pull the bridge back over the top of it. And I look at these sesamoid bones working much in the same way, right? They set themselves down just like that. The foot spins over the top of it, and then all of a sudden we get heel lift, we get toe lift, toe off, and then we're moving on, right? And then it just recycles itself every time it puts itself down. So interesting stuff, but good stuff on how we can dissipate those ground reaction forces, because these surfaces, right, the surfaces of the sesamoid, as they set onto the ground and they become stationary, that spinning of the first metatarsal head over the top of that would create an enormous amount of friction. In most cases, if it weren't for those synovial surfaces being able to just glide over each other, right? We want that to be a nice frictionless movement. But when we develop problems with how we set those sesamoids, that can increase friction and start to lead to a whole nother sort of sequela issue. Okay, let's move on here. What else we got? All right. So here we're starting to get into the true biomechanics of gait. And I think I went through kind of an abbreviated version of this in module 4 when we were talking about the mechanics of the foot and whatnot. But this really gets into a lot more specifics. So lumbopelvic mechanism in the lower limb, what we're looking at here is a way for the body to decompensate the rotational forces that it generates during gait, right? We know that we get a rotation of the trunk in one direction. Meanwhile, our legs are spinning in the opposite direction. So if my right arm is swinging forward, putting myself into a left rotation of my trunk, my left leg is going forward, putting my lower half, my lower extremity, into a right rotation. And so these rotational movements that occur through the trunk, they have to be decompensated somewhere. And so looking at this sort of thing, we get this kind of conjunct rotations down through the ankle, right? Heel strike, the pelvis starts to move forward on the hip, right? Rotating. So if this is the femoral head here, hip heel strikes, and then this kind of moves over the top of it like that, creating a relative internal rotation of the hip itself, right? Of the femoral head on the acetabulum. We have to decompensate that with external rotation of all of the joints distal to that. So the knee gets conjunct external rotation with extension. The ankle gets conjunct external rotation with dorsiflexion. The foot itself, we start to get the joint planes change because of the perpendicularity of the foot to the lower extremity. So we start to get things as abduction or adduction as opposed to external rotation or internal rotation, although we do tend to use them interchangeably. But we will get this abduction moment through the talonavicular joint, these rotational, or what we consider external rotational motions of the cuneiforms and the first metatarsals, first metatarsal as on that medial side of the foot as the foot flattens out, right? And this is something that I always want to talk about, is the flattening of the foot is a very vital component of energy absorption, right? So the ability to stretch these ligaments and joint capsules. And if we're not capable of doing this, right? And we have those patients that come in and they have these big fat plastic inserts that are limiting the ability of the foot to flatten. They wear wedges, they wear tape, they do all these crazy things to limit that. We get dispersion of these rotational forces that get forced up the limb, right? There's nowhere else for them to go other than to dig into the ground. But since the force of the foot no longer is producing those rotational forces, it has to do things going up the limb. So that can either manifest within the knee, or it could manifest within the structure of the bone, which happens sometimes as stress reactions that occur in the tibia just above that. Okay, so that's something that we do need to take into consideration. Next one, here we go, more on the foot. So as we're going from heel strike through mid stance, what should be happening is the subtalar joint will start to evert, right? It's going to start to tip medially like this. Fourth and fifth metatarsal heads will come down, they're going to hit the ground, and we're going to close pack that lateral foot. So the subtalar joint's going to evert, and what that's going to do is it's going to compress the cuboid in between the fourth and fifth metatarsals and the front surface, the anterior surface of the calcaneus. That should close pack that joint, stabilize the cuboid for us, and start to put some stretch on the long and short plantar ligaments, okay, which is great because that's helping us produce that passive energy. After that, the ankle, once we get past mid stance, the ankle is going to start moving towards dorsiflexion. What's going to happen is the talus, the wedge of the talus, as it comes up like this, is going to be forced upward into the mortise. And that's going to start to drive the fibula. It's going to push that superiorly into the undersurface, that kind of crux underneath the tibial plateau. And it's going to drive that fibular head up into that, creating a nice stable base for the peroneals to contract, okay? The peroneals, especially and particularly the peroneus longus, as it comes down, it's going to scoop underneath or swing underneath the cuboid. As that contracts, what it's going to do is it's going to pull the first metatarsal head down toward the floor. And that's essentially what's going to produce good setting of the sesamoids underneath the first metatarsal head, okay? Any number of things along that chain or along that sequence of events that affects that process can affect the setting of the sesamoids. So if we think about a sublux subtalar joint, doesn't want to evert, well, that's going to be a problem. It's going to leave the cuboid short of closed pack. That's going to maybe produce a subluxation, a plantar subluxation of the cuboid, right? The cuboid's kind of shaped like this. Peroneus longus is going to come down like that. So as that contracts, what it's going to do is it's going to pull upward on that plantar pole of that, and it may swing that thing like this, essentially pushing this plantarly down toward the floor, or pulling it, I guess is the better way of putting it. So that's something that could cause problems. That's going to affect the setting of the sesamoids. Stiff ankle joint doesn't allow good adequate close packing of the ankle, doesn't allow that that superior movement or setting, I guess you'd call it, of the fibular head. That's going to affect peroneus recruitment. That's going to affect whether or not that first metatarsal head's pulled down properly. So a lot of different things that can kind of come into effect here. If you think about the potential for an L5-S1 radiculopathy that affects peroneus longus tone, that again, that's going to affect setting of that first metatarsal head. So anything from a tarsal subluxation all the way up to a lumbar lesion that causes a radiculopathy could affect these processes. So there's a lot of things that we have to take into consideration here. And a lot of times the patient's pain response and things that sort of nature are going to be things that'll clue us into that. Okay, and this is basically what I just was talking about. Sesamoid's contact with the ground should be relatively frictionless, but if it doesn't happen appropriately, we can start to see any of these types of sequela. So patients that come in with metatarsalgia, so that plantar forefoot pain, Morton's neuroma, that's usually this burning type of sensation, something that happens kind of in between the metatarsals within the foot, can create numbness of the toes in a non-segmental pattern. Stress fractures, usually it's going to be the second or third because they're the longest ones. They're going to hit the ground first. We can get aseptic necrosis, things like that, because of the blood vessels they run underneath the surfaces of these metatarsals. We can get impingement of those vascular tissues as well. So any of these sort of things, as soon as I see this, patient comes in with a complaint of one of these types of things. All right, well, you're probably not setting those sesamoids, probably not setting that first ray properly. Why is that happening? Right? So we can look at that. We can determine, is this the tissue that's actually painful? Usually palpation is going to be good enough for most of these problems. Patient may present with things like hallux valgus, things of that sort of nature. But essentially, this is what we're looking for. We're looking for issues with setting the sesamoids in that first metatarsal head. But again, a lot of things that can kind of come into play with that, and stuff that we can discuss certainly as you get into the class or going forward during these calls. All right. Wish I would have gotten through more of this, but we can always continue.
This is better, again, to take your time and do it, but it's also good to go back over the slides, come back with questions either on the discussion board, come back ready next time with, hey, I didn't understand this portion of it. What term didn't you understand? And take our time and really work through this a bit. And this is something that we're look at even as we get into module 8 and make sure that we have a good feel for this.
Yeah, I mean, I think going through this is some of the stuff, especially when we're looking at serial lesion stuff, leg length discrepancy stuff. This is good stuff to consider. So I don't mind taking multiple sessions to go over this stuff if we need to.
So what we'll do is we'll do cases on this during MA.
Yeah, there's lots of
great foundational.
Lots of options here that we can kind of go through, because I mean, when I wrote my agenda for module 8, I really wanted it to be more about you guys determining the clinical relevancy of certain things. So I sent all that stuff to Dave, and whether he wants to go through and do his own things with that sort of stuff, I think the case-based stuff is going to be the best way for you guys to really learn this stuff and be able to apply it, because the applying it's really what matters, right? Being able to learn it and spit it back at us during a test is great. But being able to use it when a patient's in your clinic sitting in front of you, that's job number one. All right. I think, Dave, you just sent this stuff out, right? So if you guys want to take a look over these things, you don't necessarily have to push too far ahead. If you want to read through it all, you can. But if you have questions, write them down, and we'll kind of look back at this stuff again in a week. Okay.
Be good.
I think so.
Eric,
Dave,
I have a quick question before you sign off.
Yeah, go ahead.
I had a patient move to Denver that's struggling with progression with the PTA. I suggested that she go see you, but are you taking anyone like after 3 p.m.?
It depends on the day, because there are certain days of the week, especially with school starting, that I have to pick my son up at school. So I have to be out by 2:30, 3 o'clock on those days. So I usually will be available Tuesday, Thursdays, most often in the evenings. But it kind of depends on the week. So
okay, I just know she couldn't find anything. I'll just tell her to call.
Okay.
Like on the online, there was nothing after 3.
Yeah, well, summertime, my son's still home, and now his summer camp's over, so it's been a tougher time trying to find things for him to do during the day.
That makes sense. Okay.
So
Thanks.
right. Yep, you betcha.